What's up, everybody? It's Dr. Torrance, and I'm here with Dr. Pappas, my friend, colleague, and partner for 8 plus 9 years now. And I am pumped. We are going to jump on and answer any hot topics here in regenerative orthopedics that we think are something that people would like to hear, or you can drop down here in the bottom. You can drop questions. I'll take questions from some of our streams here and see what we get. It's our lunch hour hot topics. One of the hot topics I want to talk to Dr. Pappas about, we're talking about right now, we have a Zoom going on with Felipe Hernigau. Dr. Hernigau, pioneer of regenerative orthopedics, and Regenix is rolling out right now our IO protocol, which is interosseous protocol for injecting into the bone for arthritis, for ankles, and also for shoulders. We're moving that and making it something that's more of our protocol because of how good are the studies that Dr. Hernigau did. Dr. Pappas, you want to kind of riff on that and talk about your experience? I'm doing an ankle this afternoon, and I'm also doing hip this afternoon, IO. So something to really kind of jump in and let me hear your thoughts about that.
Yeah, so when we talk about joint health, a lot of the things that people initially think about are the cartilage that lines the bones of the joint. But what the studies from Dr. Hernigau have shown is that actually when we're treating an arthritic joint, we get more out of the treatment if those treatments target the bones of the joint. So the cartilage actually gets its blood supply from blood vessels that live in the joint. And we know that if the bone is compromised, the blood supply to the cartilage becomes compromised, and the joint, cartilage, and other structures of the joint will eventually wear out and become compromised themselves. And so the idea behind injecting joints at the bone level is to try to help what we analogize to the soil of the joint, because that's where the supply for a lot of the structures in the joint come from. So if we can get the bones healthy by injecting them, in a lot of cases, Dr. Hernigau's work has focused on injecting mesenchymal stem cells from bone marrow into the bones. If we can get those bones more healthy with that type of technique, then the cartilage can become more healthy, the rest of the joint, the other structures can become more healthy. And most importantly, the patient can get improvement in their pain and function and avoid things like joint replacement surgery.
Yep. And I was showing a shoulder here, and this is something that really we've seen substantial data on hips and knees. And Dr. Hernigau is presenting today to our Regenix folks. We're talking about shoulders and ankles. And ankles, one of my least favorite joints. The really good alternatives for an ankle is not least favorite joints. It's one of my least favorite joints to hear people are having to get ankle replacement surgery. Those are awful surgeries, very long recoveries, and a lot of times the juice is definitely not worth the squeeze, in my opinion. Otherwise, they're getting a fusion, and you're going to have a stiff leg for the rest of your life. So injecting the bone shows that it's shown with his data here, we're seeing huge improvements on the scale of zero improvement on the controls to about 3 points down on the pain scale. But that's a 2-point elevation in the control and a 3-point. So it's almost a swing of 5 points on the pain scale from getting worse and then doing these procedures. So it's a huge improvement for most patients, whether it's shoulder or ankle. And that's why we're adding it to the Regenix protocol. So that was cool to hear today. And Dr. Pappas, what have you seen with patients with ankle arthritis and then shoulder arthritis? What are you seeing outcomes wise?
Well, I mean, first of all, I agree. Those replacement surgeries for ankles are tough. The other issue is too that the blood supply in general is not as good once we get further away from the heart, and so the risk of infection goes way up when you're talking about an ankle replacement. And when in any joint replacement, that's the thing you worry about the most, is a prosthetic infection, because in the case of an ankle, if you can't control that with IV antibiotics, you're looking at a below the knee amputation. But in terms of outcomes with injecting orthobiologics into ankles, I think ankles tend to do as well as knees. they're a little trickier to inject in terms of the IO injection, just because there's more neurovascular structures. And so you have to kind of triangulate where you're injecting really well with the ultrasound and the X-ray in order to make sure that you're doing the procedure safely. And so the true ankle joint is the lower part of the tibia, which is the big lower leg bone. And then the next bone at the joint line is the talus. And so usually if somebody has bad osteoarthritis, you're injecting into both of those. You're injecting into the distal tibia, and you're injecting into the talus, which is a smaller bone, and those make up the true ankle joint. And so if you're talking about injecting IO into the ankle, most of the time you're injecting those things. Although the ankle is tricky because after the talus, there's a number of other bones that happen, and the connection between the talus and other bones like the navicular or the calcaneus can also develop arthritic changes. And depending on the patient's picture, you may inject not the talus and the tibia, but the talus and the navicular, or some other combination, just depending on how and where the arthritis is in a particular ankle.
No, fantastic discussion there, and that's definitely one of the things they dove into on this presentation, talking about whether you're injecting the higher ankle bone, the tibia, or the talus, which is the lower ankle bone. And he actually broke down some of the data there, which I'm super, super interested to dive in. I took some screenshots so we can talk about it at another point. But these injections of the bone are definitely game changing. We're the best in the business doing this. I don't think that enough physicians know the risks and benefits of these injections. I think that probably, I would say, less than 1% of the clinicians in the world can do this. What would you say, Dr. Pappas?
Well, I mean, let's say just even in the orthopedic space, right? And even people that do regenerative injections, right? The vast majority are injecting just into the joint. Probably the biggest bucket are people injecting things that may or may not be regenerative, called regenerative things, with blindly into a joint space, right? Yeah. And then after that, you got people who are injecting good things, but also blindly. And then after that, you got people who are injecting good things into the joint space with guidance, right? And then after that, now you have people injecting into joint space with guidance, as well as other structures with guidance, including intraosseous injections. And so by the time you get to that intraosseous tier, it's not a lot of physicians that do that overall. We're located in St. Pete, Orlando, in Tampa, and Sarasota, and I don't know of anybody else in that region that's doing intraosseous injections with image guidance of these types of materials that I'm aware of anyway.
Yeah, I think that's a super, super niche space and super, super unique injection that if that's not happening, or you're a clinician or your doctor's not talking about that, it's definitely something called a subchondral or interosseous injection that really has seen the best long-term outcomes for arthritis. And if they're not doing that, you're definitely not getting the pinnacle of orthobiologic or regenerative injection. So again, you brought up a great point too. Sarasota, Tampa, St. Pete, and Orlando. Dr. Zakis and I were doing this on Tuesday, and then Dr. Pappas is in Tampa. He sees patients out of the Tampa office and is a fantastic clinician up in that space. So one of the things that I think that people think about interosseous injections, and just bringing it up because I think it's a super fantastic topic. I described it yesterday as to a general contractor because I try to really make my analogies something that people understand. If you're ever pouring a slab of concrete, and this really goes really well with a general contractor, there are things you do to make the concrete make it stronger, right? And when you pour it, you put fiber. Fiber is one of the things you can put in there, and you can put wire mesh, okay? And so these are things that you can do to make the concrete stronger. But here's the same instance. We're going to make the bone stronger by injecting your body's own cells that are from your iliac crest, and they are concentrated and they're put precisely in the right place where you're having edema and inflammation in the bone. And we're going to put that there to make that ankle bone, the subchondral bone, but also the cartilage on top healthier and stronger. So I think it's a good analogy and good visualization for anybody who has kind of more of a general contractor mind. Dr. Pappas, what do you like to use for your kind of analogy there? How do you kind of compare that?
Usually a tree or a plant.
Okay.
I think of the bone as kind of the soil. I think of the things growing in it, like cartilage that rely on the soil.
Love that.
cartilage, meniscus, and then other support structures like the ligaments and things like that. But they all need that support system. And so if the soil dies, then the plant dies, right? Whereas if the soil is strong, the plant can recover and can be healthy.
Great analogy. I love that. And that's what we're seeing here with the data from Dr. Hernigau, a really pioneer game changer for regenerative orthopedics. He started with hips, he went to knees, he's done shoulders and ankles, and he's got fantastic data. So that's one hot topic that I want to talk about today. Next hot topic, how can you identify a clinician who's doing a procedure that they probably shouldn't be doing? Or what are some red flags if you went into somebody's office that would alert you, Dr. Pappas, that that person is not doing a quality procedure?
Yeah, there's a lot there. And I think it's hard for patients, without a medical background, especially to know, especially in this space, because it can be the Wild West out there. And how do you know that the provider that you've seen is the one that's going to do a good job? A couple of things. I mean, a lot of training with image guidance is super important. And then a lot of protocols in terms of sterile technique, and so, these types of procedures can be done in the office, but they should be done in a sterile way with sterile drapes, with probe covers, with staff who are also sterile to help assist in a way where anybody who is sterile is not being touched or contaminated by anything else. And so, it can be, I think, tough, for people to know right away, but there are, red flags, asking where the procedure is done, the technique that's used. A lot of times, even if the patient's not savvy, you can tell somebody who really knows what they're doing, who can describe how to do something with proper procedure. Asking about has the provider had infections before? I've done many thousands of these types of injections. Knock on wood, haven't had any infection yet. And part of that is because we use sterile technique, and part of that is because the substance that we're injecting has inherent antibacterial properties to it. And so an infection should be extremely rare. And if somebody is getting infections on a routine basis, that's a big red flag for sure. And that's the thing that fortunately, they are extremely rare to the point where I haven't seen one in 8 to 9 years of doing this with our practice. And but so if somebody is getting infections, then obviously there's some disconnect. Either they're not doing the procedure properly, or possibly the lab where the product is handled may be a source of contamination for that particular provider. So those are kind of some concerns that I would arm patients with when they're looking for a good provider for this type of procedure.
And there's one clinician in particular right now that injects things that rhyme with fuse cells that we're hearing about in the news media at this point. And it's a little concerning when somebody is getting products from someone else or somewhere else. That is one thing that I would say at this point, there are no reputable labs that are supplying allogenic substances. So allogenic meaning coming from somebody else. Those allogenic substances, we don't have any reputable suppliers that have gone through the rigorous 3 phases of FDA trials to make sure that these things are coming from real places. So if somebody's pulling their fuse cells, something that rhymes with fuse cells, from somewhere else, I would definitely run away from that person, and I would be very, very concerned. There's a lot of infections that have happened recently with said person, and I would definitely make sure that's a red flag in my book. We use autologous cells that come from your own body, platelet-rich plasma, bone marrow concentrate, and in some cases for a structure, we use MFAT. And knowing it comes from your own body in a sterile procedure is something that's going to make sure that we're taking that and then utilizing it in our sterile lab to make sure we concentrate it and put it back in your body under ultrasound and fluoroscopic guidance. So I'll let Dr. Pappas kind of, muse on that subject, but go from there.
So, when you talk about injecting a patient with substances that are not from their body, and supposedly these are substances that help that person heal, it's difficult because if there are living cells that are being injected, that can be dangerous. There is such a thing as a stem cell transplant. People do it when they have leukemia or certain kinds of blood cancers. And in order for one person to donate their stem cells to another, they have to match 10 different genetic markers. If they don't, then when you put somebody else's stem cells in your body, those stem cells may attack you. It's called graft versus host disease. It kills people. Even sometimes when those genetic markers match up, it's extremely dangerous. In the case of somebody else's cells being put into your body for supposed regenerative purposes, I mean, we don't even know the blood type of that patient, let alone these other 10 different genetic points. So the way that people get around that is because any cells coming from somebody else's body are dead. They've been irradiated usually in order to sterilize them. But at that point, when they're injected into you, there may be some proteins that are interesting, but there's no living cells that can do things like regenerate tissue like they're often being purported to do. And then to piggyback on Dr. Torrance's point, right, these are coming from usually a compound pharmacy or a lab somewhere that is not necessarily regulated, and in these labs, something called LPL or a lipotoxin particle that's often a common contaminant can get into these types of products. If it's injected into, it can cause a bad reaction, it can cause infection, and people can get really hurt. And so you have to be careful when you're talking about injecting yourself with cells that are compounded in some pharmacy, supposedly from somebody else's body.
Absolutely. Well, listen, I've got patient care to do this afternoon. I wanted to make sure we got on here and got this party started. I'm super grateful that Dr. Pappas and I are going to try to be doing this every third Friday at 12:30, lunchtimes with Dr. Pappas. And he's in our Tampa location. Please make sure you get in there and get a consult if you have any questions. We take most insurances for consults. I'm in St. Pete today. I go between St. Pete and Sarasota, but we serve Sarasota, Tampa, St. Pete, and Orlando, trying to deliver the best care for our patients and help you avoid surgery through image-guided injections with orthobiologics mostly. And Dr. Pappas, thanks for taking your time. Any last words before we pop out here today?
No, great to be here. Great to see you. Hope everyone has a great weekend.
All right, brother. Be good. Have a good one. Thank you so much for your time, and we'll chat soon.